This is All Things Cancer, the podcast of the National Foundation for Cancer Research, hosted by NFCR President and CEO, Dr. Sujuan Ba. Each episode explores the hindsight, insights, and foresight of cancer research and care, and how NFCR and its partners are accelerating the path to cures.
Hello, everyone, and welcome back to All Things Cancer. I'm Dr. Sujuan Ba. Today, we have a very special episode, one that brings together personal history, national leadership, and a powerful vision for the future of cancer research and patient care. I'm joined by Dr. Monica Bertagnolli, a surgeon, physician scientist, former director of the National Cancer Institute, former director of the National Institutes of Health, and one of the most influential medical leaders of our time. In our conversation, Monica reflects on her remarkable journey from a cattle ranch in rural Wyoming to leading some of the most important scientific and medical institutions in the world. She shares how those early experiences shaped her deep commitment to underserved and frontier communities, and how that perspective continues to influence her work today. We also talk about the moment we are living in, declining federal research funding, the strain on the scientific workforce, and the real consequences facing young scientists, cancer research labs, and the future of medical discovery. Monica offers candid insight into what this means for our nation and why public support has never been more essential. And finally, we look ahead. Monica and I discuss the promise and challenges of artificial intelligence in cancer research and clinical care. What will it take to build trust? And how do we create a true learning health system? And how can we make sure AI benefits every patient in every community across America? This is one of the most inspiring, honest, and forward-looking conversations I have ever had. One that I hope sparks reflection, hope, and a renewed sense of urgency for all of us who believe in the power of science to save lives. Let's get started. Hi, Monica. It's wonderful to see you again. How was your flight coming down from Boston?
It was late. 2 hours late. Always late. But it was okay.
With your job, you're flying back and forth everywhere. So how are you dealing with that?
I will tell you how I deal with it. My son says that the airline lounge is my mom's office.
And free of rent.
Exactly.
That's fantastic.
They have coffee, and they have place to plug in my laptop, and they have internet. What more do I need in life? So I spend a lot of time in airline lounges.
The last time we sit down together, that's 2023.
Oh, wow.
And you were the Beacon Award recipient from AIM High Accelerator Fund.
It's been a very intense 2
2 years
since then. Yeah, lots happened. It seems like 10 years.
Always amazed about your career journey. And you mentioned the last time you were raised in a cattle ranch in
Cow ranch in
Wyoming.
Wyoming. I'm a cowgirl. Truly.
Do you wear
Truly
cowboy boots and cowboy hats?
I have them, and I wear my boots when I'm home in Wyoming. I don't wear my hat very often, to be honest. But
still have families in Wyoming?
Yeah, we do. We still have the family cattle ranch. Is still a working cattle ranch. It's a wonderful place. And it's just like it was when I was a kid. There's always so much work to do. This summer we spent the entire summer rehabilitating the original homestead for the ranch, which is 140 years old. This little cabin, this little kind of 3 small room cabin that some incredibly resilient person came and cut down the logs and built this log cabin and lived there in the middle of winter, high in the mountains of Wyoming. I mean, it was really quite humbling to see what the people who came before us actually did to survive and thrive in parts of this country.
And that's the part I always believe get you rooted.
Exactly.
About the underserved communities,
yes.
underrepresented communities. And you have a very personal experience of seeing everything in the rural America.
Absolutely. It's not getting easier in rural America than it was when I was a kid. Most recently, though, we've had an amazing success. There was no hospital.
No hospital.
Really, in this small
Wow.
community, this small ranching community, there hasn't been a hospital there for quite some time. No maternity services, and it's, people need to drive 2 hours, 3 hours for any kind of services. So a wonderful thing happened over the last 7 years. The community worked really hard to get a new hospital, and it is a 3-government collaboration to build this new hospital. Are you ready? The federal government, U.S. Department of Agriculture development loan, the state of Wyoming, another grant to this region to build a hospital, and the third government, the Eastern Shoshone tribe,
Wow, is that
who gave the hospital the land where the hospital is being built. And then the community raised money itself. So it is very touching and also inspiring to see what that little community was able to do. It took them 7 years to get everything ready to go, and the hospital will open its doors within the year.
Unbelievable.
So it's thrilling.
Such
Yeah.
a wonderful story.
Riverton Regional Hospital. So we're very
wow.
excited about it. So I got a license to practice medicine in the state of Wyoming.
Oh, wow. Specifically for that reason.
Well, to be able to maybe advise them from time to time when I'm there. So I'm really excited, and I'm so thrilled for them because it just illustrates what happens in so many of these frontier communities. Nobody was going to do it for them. So they all got together, the community, and they did it together, and I'm so proud of them.
You have such an amazing career. From a girl on the cattle ranch, you thrived to become the chief of surgeon and the director of NCI, all the way to being the director of NIH.
Well,
what a journey,
I had quite a bit of help along the way. Okay, I was very fortunate, really, incredibly fortunate. I was able to go to a really outstanding college. I was able to go to medical school, and in a place that also had a very active community based in rural America, University of Utah. It was my state medical school because Wyoming doesn't have a medical school. Mm-hmm. And then I was able to receive an education in surgery in Boston at Brigham and Women's Hospital, and to do get research training at the Dana-Farber. And it was very, very exciting time when I was training there because we were seeing the very first clinical successes for immunotherapy. This is in the late 1980s,
yes,
early 1990s, and it was what an amazing place to be. With surgeons who were doing incredible work in the field of oncology, and just look how that field itself has advanced over the last 35 years. It's just amazing.
Amazing.
Very nice to
So when
see.
you started, I bet not a lot of women surgeon trainees. How did you thrive in the all-man surgical world and become the first women chief of surgeon at Dana-Farber?
It was, I thrived the same way everybody did. We work really hard to take care of patients.
Yes.
That's the nice thing about an environment for medical care, even surgery. You are so needed there to take care of patients. Your job is to do a fabulous job taking care of people.
On the notice of moment, you have to be there.
Exactly. And so the immediacy of caring for sick people all the time kind of blows away some of the other issues that are floating around, right? So focus on taking care of the patients, work really hard, and everyone works so hard. And then focus on the science and the research. And I was very fortunate to have had great opportunities when I was training, and that then continued after that. Lots of hard work and just focus on the job.
I think there must be other softer skills that enable you to lead well, and being, chief surgeon. That's not an easy job, and probably that kind of soft skills and special traits, besides the hardworking, taking care of a patient and doing great science, because many people are doing that, but you are able to really thrive in that environment.
So I think I really have fun.
That's the biggest part.
I know, I really have fun. Now, that doesn't mean that there's not a lot of things that we all have to do that are sometimes absolutely heartbreaking. I mean, medicine,
yes.
Certainly cancer, taking care of people with cancer, absolutely heartbreaking at times. So, your humanity has to be in everything you do, and that can make it very hard, but you also get to see the wonderful successes and what is to be a part of those successes. How can you not just want to get up and keep going when you see that, right? And to really believe in what we do. And then there's another part that you don't hear doctors talk about very much, but when I was doing surgery, it was actually never far from my mind. I took care of a lot of really sick people. I did a lot of soft tissue sarcomas, large abdominal sarcomas, where people were really sick. And surgery was the best chance for them to sometimes not be cured, but at least live a better life for longer and live with good health. But surgery could be risky and things could go wrong.
Yeah.
And the other thing was just, I was always awed by the trust that people put in me and never took it for granted. I mean, think about this, think about the kind of trust it takes for a person to let have a surgeon take them to the operating room and do a surgery that is risky, but we're together doing this because it's their very best chance to have the best life they can. And so that is another thing that how could you not want to do the very, very best you can for that person when they give you that kind of trust?
I think that is a driving force for you and making a difference. Beyond just your immediate circle of patients you are taking care, you have much bigger vision and desire to change the paradigm and change the world for a lot of patients. And is that the reason you started a clinical cooperative group and be a president of that for more than 10 years?
Yeah.
That's like herding the cats.
The reason I was working in the cooperative groups in the first place was, even back then, I loved the laboratory. I loved studying tumor biology, but I also knew, being a clinician, that only mattered if it mattered to the people I was taking care of. And working within the clinical trials was the best opportunity to do research where you were linking what you knew in the laboratory directly to a patient.
I totally agree with that.
And so I was doing that. That's why I went to the cooperative group. So, I joked at one point, right? Oh, the only reason I'm glad we're running these trials, but even if they fail, even if this trial doesn't succeed, it's going to be a success for me because I'm going to have the tissue bank. And I'm going to be able to use those specimens for the science, So no matter what, I hope it succeeds, but if it doesn't, we're going to still make a success of it because we can study the science.
That's
of
an
like
integrated
some
system.
people did well and did badly. And then so my lab was active. I was doing a lot. And then I had the opportunity came to maybe run the group. And it was very interesting because I went and asked a lot of colleagues. I always do this. Whenever there's a big decision to be made, I ask the people I admire and respect, what do you think? And I remember at the time asking a bunch of my colleagues, and I asked 5 wonderful advisors. 4 of them said, don't do it. 4 of them said, you have such a promising research career. You're going to have to give up your lab. You're going to just be doing clinical trials. Why do you want to do this? And then one person said to me, Monica, you could have tremendous impact if you run a group like this. Or things completely beyond your control could make it just not worth it and it'll all fall apart. He goes, I think you should do it. And he was right.
Even
he was right.
when they fall apart, you still get insights.
Well,
why they didn't work.
It was a scary time.
Yeah,
but the point is, that was the chance for real impact for patients, for people. And, you know, and it was a bigger opportunity for me to have more impact. And that's why I said yes.
And you did make impact, and you changed quite a bit the system, right? Mechanism of running those clinical trials and making it more efficient.
We did. We went a lot of different directions. I'll tell you, one of the things I did coming in the door is I said, we had a 5-year plan. One of the things in my 5-year plan was at the end of this 5 years, I want to see our minority and underserved recruitment to our clinical trials be 30% or higher. I want you all to do it. And they did it. They did it. And so that was one of the things we were very proud of it right from the beginning. Well, I set them the challenge and they delivered. You know, another one was we started partnering more with pharma to do trials with the same kind of transparency and accountability and patient engagement and access to the data, you know, public access to the data that we did within the NCI-funded trials. And, you know, so we created a little limited liability corporation to be able to do Alliance Foundation trials. That brought many opportunities to the team that we wouldn't have had unless we were able to partner with pharma.
And that's a very innovative model, public-private partnership to do trials.
Well, believe me, I didn't come up with that idea on my own. You know, I had other amazing mentors. It's not something I invented, but we made it happen. But we made it happen, and we made it work. So I'm not going to. I'll take credit only for, you know, shooting off another branch of what others had started. That was really fun. And then the last thing we did, which something I continue to do today, is we started an effort working with the FDA. And this is around the time of 21st Century Cures, when they said, when the FDA had a new requirement to use real-world data to make regulatory decisions. We started an initiative within the clinical trials group to make real-world data better. You know, make it the kind of data that people could have confidence if the FDA made a regulatory decision that it was the right quality of data. And we started working with the FDA on that. With a number of partners. I had a wonderful statistical team, Smithra Mandikar, Stephen Piantadosi, helping us do this work back and forth between the electronic health record and the way we do clinical trials. And that set the stage for a tremendous amount of progress that we have forward even to today, that is now, for the first time, starting to make real data from the clinical care environment the kind of data we need to really use for AI applications. It needs to be so much better than it used to be, and all that little thread continues to go, and we're getting there for that too.
You were ahead of the curve back then, and setting up the partnership with the FDA.
I'll own that one. I think that one we were ahead of the curve.
Yes.
And it was because, you know, it was the view of a clinical trialist saying, why can't data from clinical care it's not going to be a randomized trial, but why can't the records that are kept in clinical care be as as careful and accurate as the records we keep in a clinical trial? And the answer is they can.
Agree. They could.
They can.
Yeah.
You just have to use technology in a different way.
And you have to
now
have the commitment.
Getting systems as big and difficult to steer as major health systems is not easy for anybody, not even the leaders of major health systems.
That's why I think
just takes
you have made
persistence.
such an impact for this cooperative trial group. Yeah.
Well, I'm very pleased, and I can tell you when I left, which was in 2022, I am very, very proud to say that they're going way beyond anything I started. They're just still thriving, and I hope that the cooperative group mechanism continues to be very strongly supported by NIH and NCI, because it is a treasure. It really is. The other thing that is so important about the cancer groups I hadn't seen across anywhere else in NIH is that it reaches almost every community. You know, because it's a collaboration between major academic centers and community cancer centers and networks, it's doing what we need to do to eliminate disparities. It's reaching every community. And how do you think we got 30+% of our patients on those trials from minority groups? It was because we had that network that really did span all of America, not just certain favored parts.
Yeah, because 80% of the cancer patients are treated by the community oncologist. Only 20% of the patients go to the major medical center. And so the impact is profound.
And in the groups, some of the clinical enrollment sites for those groups are in small 1 and 2 doctor practices, and others are in, the biggest medical centers in the United States. I mean, it goes across the entire gamut. I also am very proud of our community of oncology, because participating in clinical research for oncologists is a culture.
Yes.
It's just...
They are so busy.
Everybody.
Resource
it is so part of our culture across the board, you're right, community, academic, everywhere. And that's not something you see in all of medicine. That's something very special to oncology.
Cancer. Yeah. And you go on and you become the president of ASCO, and from there you become the director of NCI. So tell me more about your insights from that 1 year as a director of NCI before you were tapped away to lead the NIH.
Larry Tabak, the wonderful deputy, he was the interim director after Francis Collins stepped down. Just such a talented, funny man, wonderful and also funny man. He had a great sense of humor. He said, "Monica, you were just at NCI for a cup of coffee." We were
surprised.
I'll tell you, I was so thrilled to be there, and there were so many things I wanted to accomplish. And the team.
I remember.
Right, and the team was so behind me. They supported me completely, and we got a fair amount done in that 1 year. We got a lot done in 1 year, and then over to NIH, which was also...
That's much more complicated, challenging.
Very complicated, but again, such a rewarding experience. NIH was a very, very special place.
And I hope we keep that special place intact.
Well, I think there is a nationwide an appreciation, truly, for what NIH has done in the past and for what its promise is for the future. I don't have any worry whatsoever that we're not...
I think we get more and more appreciation now because this kind of system at jeopardy.
Yeah,
people
maybe
started to realize the true value of a system like that, agency like that.
Well, it's been the envy of the world for researchers who want to have their brilliant ideas funded and to support. Also, I think people forget a little bit that so much of the infrastructure for research came from NIH. I mean, where do you think those indirect cost rates that everybody complains about so much that get attached to grants? Well, that's the infrastructure That's the personnel office and the
Keeps the lights on.
the lights and the freezers and and the buildings and the equipment. So many things that are absolutely essential for the work. That money went to very, very good use across our health enterprise. And so we're going to see. I believe in the people who are able to, who are being granted the opportunity to do the work. They're going to make the very most of it.
You think they're going to make the right decision?
Oh, I think our researchers, I have no problem whatsoever in having great faith in our research community. Absolutely. They will do spectacular work. There is so much to be done. I do sincerely hope that the funding will continue.
There's so much concerns.
There's so much
uncertainties now.
Right, and leaving that promise on the table would not be good for anyone.
What do you think it would do for our nation and for the world?
So I truly do not believe that work of NIH-funded researchers the entire time I was there was wasted in any way. I really don't. I think, I saw the result every day. I was amazed at what was produced by our nation. And
that's why our nation is still the
leader
in the world.
So I don't think, I think it is widely recognized that investment from the American people produced incredible payoffs for the American people. I've seen the analysis, economic return at $2.61 per $1 invested, economic returns that went to many, many different communities across the nation, businesses, productivity, new drugs, all of those things. I think it's widely recognized that the investment in the NIH was very important and produced amazing things for the world, frankly, the American people and the world.
A lot of people are very worried now.
Yeah.
I heard so many people telling me their labs are at risk of being shut down or reduce the scale and letting people know.
Yeah, no, I know it's been very, very hard on the community. And I think there were a combination of things. First, there were things being canceled, and next there was just the uncertainty. And we're still in a time of uncertainty. We don't know. We saw recently, I was really delighted to see the House of Representatives budget supporting the NIH at the funding level equal to what we had seen in the last year I was there and this last year, which I thought was just a wonderful validation from both Republicans and Democrats together that yes, NIH is worthy of that level of funding. So that was nice to see.
So we might have 1 year certainty for the funding intact situation, but
we don't have a lot of certainty about what our future holds. We're still waiting to see our budget for this year. But like I said, we got some really great encouragement from a bipartisan team on the House side, giving NIH that vote of confidence again that budget is appropriate.
UK, the two major founders are private. So it's a Cancer Research UK, it's a large cancer research nonprofit, and the Wellcome Trust. And the research communities don't necessarily rely on government funding, so they rely on public support. And in a way, the research funding are more stable and don't get interference from government funding that much. But in US, it's quite opposite, right? Even though we have a very flourishing nonprofit sectors, lots of private citizens give to charities, and charities support research programs like NFCR. NFCR is supported by grassroots donors for 52 years, and so that we could really support some cutting-edge, critically needed discoveries. But majority of the funding are from the government.
Right.
So that make it the whole research community very sensitive to the political turmoil or environment, I should say.
Yeah.
So perhaps this is a weakening moment for America, that we should have less reliance on government funding. We should reinvent or rethink of a new funding mechanism, funding system.
Exactly right. No, exactly right. And I think we're seeing that happening now. We're seeing some shifting. We're definitely seeing I'm sure the philanthropic community is seeing greatly increased demand, as these really
absolutely
worthwhile projects are going unfunded because of things that are happening on the government side. And so I know that's increasing pressure there. It remains to be seen what this time we're going through is going to do. The last time wasn't nearly this level, but we saw this somewhat at the time of the sequester. Remember, we had big advances, and then we had a bit of a cliff that we fell off of. And we lost some serious ground at that time. Fortunately, it was relatively brief, and this is probably longer and more severe. We'll see.
Setback probably will be felt several years down the road.
Oh, yeah.
I'm especially worried about younger generation of people going into science. This is such a discouragement, setback for them to be willing to go to biomedical research.
I hope we can convince them to keep pushing, despite more challenges. I can tell you, the young people I meet with, have never taken it for granted. They've always known that it's a challenge to be in this career.
So people who really wanted to go into biomedical, they really love to go to biomedical.
I haven't met with a group of aspiring scientists or aspiring who felt it was just going to be an easy path. And I don't see them wavering right now. I think the ones that it's the hardest are the ones who are now just completing their postdocs, just finishing their training. That middle transition is
hard.
I think that's really hard.
I heard numbers from somebody today saying the Harvard's graduate school admission reduced 75% this year. MIT 50% reduction. I was shocked how quickly we get to see those kind of impact.
We had many, many discussions when I was at NIH about how graduate positions are placed on grants, or the dependence of graduate level positions on the grants. It was one of the things that we tracked very carefully. Mm-hmm. You probably know, when I was director, we had an initiative to raise the salary and raise the benefit levels for graduate students and postdocs. And that was a really...
It was a big news from California. They were on strike.
It was so desperately needed, you know, and
they
all
need to have
that,
a living wage.
Well, and a lot of it was borne by the institutions themselves, but there was a lot of pressure on NIH for that as well, because of the dependence of those actual positions on NIH funding. Mm-hmm. And now you're right, that is, the withdrawal of that, or the decrease in that, is really going to have a real big effect.
This kind of reduction is going to be felt in several years, and it's going to be hard to catch up. Yeah, that's what I worry. Well, let's talk about
more
better future.
Happier
Hopefully,
things.
we don't need so many manpower, right, in AI age, right? So let's talk about AI in cancer research and in patient care. I wonder whether you have engaged in any policy and regulation for AI data or...
Okay, well, I'm very glad you asked this question. It was the topic also of the National Academy of Medicine meeting. And it's very clear these are incredible tools. just truly incredible. The work that's being done with AI in fundamental science is just thrilling, astounding. In clinical care, it's been very, very difficult for so many reasons. Our health systems are incredibly complicated. One of the speakers at the conference mentioned that, they had developed this wonderful AI tool that allowed their hospital to take care of patients with a particular condition. And it worked great in their hospital, but when they tried it at the hospital down the street, it wouldn't work. Didn't work.
Didn't work.
No, well.
Is that because of the resistance, or it's because of the lack of applicability?
Well, it's because healthcare is incredibly complicated. And in order to train AI methods and use them reliably, you really need very, very detailed data on individuals at large number, and you have to include every kind of individual in that analysis. And it turns out we are learning that patients in one city or in one county, in one state, are very different, and health systems and health delivery and all the things that go into deciding what's the right, absolute right thing for this person to get a good outcome is different depending on where you, believe it or not, can be different where you are. We're learning that. AI is teaching us that. So what it is teaching us is something I think the national academies have said for a long time. We need a learning health system that includes everyone. We can't learn from patients in one place, expect it to work in another. Everyone needs to contribute to learning to receive the benefit. So that's one high level.
I'm so glad you said that.
Yes,
that's
everyone.
That's one of the new initiatives I am pushing forward at the National Foundation for Cancer Research. With the lab discoveries and machine learning, you still need a patient to participate. So I have been trying to really get together the support and experts together to build a patient community hub where I will have a one-stop resource center. I call it research center or hub center. I will also try to set up a sandbox for people to learn about digital trial and clinical trial. And that sandbox can bring patients, AI, and the clinical researcher, and basic researcher, and even we can bring policy people to see that. And the patient didn't have to be worried about losing their identity, privacy, and
of course not.
Worried about the security.
One of the things that's incredibly important, though, in AI in medicine is you can never take the human out of the loop.
Exactly. So we have to. If you can build a patient digital twin, they can put in their information.
And we can use it for research. Right.
Exactly. So it's a patient feedback, feed in for our clinical research and our diagnosis training, things like that. It's very challenging. I've been gathering experts' opinions. I'm getting different opinions, like you said you would, right? I'm getting different opinions. And the more I talk to different people, the more I'm convinced we need a systematic approach to build this kind of loop, the system, everybody contribute.
So anyone who's interested, the National Academy of Medicine Learning Health Leadership Consortium, which has its learning health, is building the learning health system, just put out two, I think, really important documents, two publications. One of them is an artificial intelligence code of conduct for the use of artificial intelligence in science and technology and health. And then there's another one that's a specific document from the Learning Health System group that's about the use of artificial intelligence for health. These documents, like these National Academies products, were done with a very large group of stakeholders who have been working on this for quite a while, and they came out over this summer. They're definitely been out since September.
I have to look at it.
Yeah,
really.
you should take a look. I think they are a really good roadmap. Things will continue to evolve as we go, but I think these documents really do set some guardrails that we all need to think about as we develop applications and we develop policy to govern applications.
That's wonderful. I'm going to take a look at that, see whether we will be able to participate and contribute to this
Very nice.
new kind of science. But I want to get to one critical point, applicability. I have heard from enough people saying even though some of the AI-based diagnoses are so good, pathology related, but it's very hard to get the hospital system to take it because the pathologists already are used to the way they are running the test, and the hospitals don't have the extra money to pay for those so-called AI tools from the companies that are developing. What's your view about this?
Well, I mean, I could just say in general, these new approaches, we've been doing this forever, something new. It could be a new kind of radiotherapy. It could be using a robot for surgery. It could be this is yet another new technology that we're entering into healthcare. And that always puts it on us as the research community to be really sure that this new thing is giving better outcomes for patients. It is truly improving people's health chances to survive their cancer, but whatever valid mark you can look at. Once we show that it is clearly better for a patient outcome, then you've absolutely got the argument, no matter what, that it needs to be adopted. I don't think we're there for some of these AI methods yet. They're still getting that evidence, that usability and evidence and proof. And I would love to see our clinical research community really get behind this, in our health systems, get behind this in a positive way to give those developers the data they need to get it, because it's all data dependent.
Yeah.
Really dated. And so I would love to see us really get behind it, because I do think the promise for patients is enormous, but we've got to do the homework to prove that this is really better.
Data.
And it's got to be
real-time data.
Right data, and data that links to outcomes that matter to people. And then the last part of it, you've already alluded to this, both the doctors and the patients have to trust that this thing is really the thing to do that will be better for them. And that's something that we all need to work on. Remember back to how I was so humbled by the trust that my patients placed in me. We really need to have that same attitude about these new tools.
New tools, right?
We have to earn that from our patients, because these are lives here. So that's a critical part of developing these new tools.
So for molecular sequencing, next-gen sequencing to be integrated in the patient care diagnosis, treatment guidance, it took about 20 years. Mm-hmm. I remember when 20 years earlier, when NFCR was founded to get the truly important patient data to show to FDA and to show to the community, these kind of tools will help patients. And it was $100,000 for each patient. I remember we paid $1 million to sequence 11 patients back then, 20 years. And now some of the sequencing only takes a couple $100. So, but it took 20 years. What do you think the AI journey would be? How long would that take us to take from today at the beginning of the application to the time that everybody will buy into it and use it for patient care?
So, speeding up the process of all of health, progress in all of health, has been core to this National Academy's Learning Health System program. That system's been around 20 years. But there's so many tools now, so many new approaches that tell us how to build a learning health system. We are now starting to see some institutions applying those learning health system approaches, and basically it means you are collecting data, learning from the clinical environment and the research bench, and putting that information into a learning loop so that you're applying new knowledge and then learning from what it feeds back, and you're doing that continually. That's what a learning health system is. So now, after 20 years, we're starting to see application at the health system level, like we haven't seen before. But now we have AI. And AI has an opportunity to be a complete game changer when it comes to learning health, because you cannot achieve AI, the promise of AI in health, without data that can be collected safely and reliably from everyone. And so what I hope, because the technology to allow that data to flow has been there and exists today, what I am hoping is that the promise of AI is going to finally let all of us as a nationwide health environment take that next step of sharing and collaborating across our silos, so that we really do have a learning health system that's starting to work for everybody. That's my hope. It's a social engineering problem, not a technological problem.
I can see that. It's not just science.
And I think the national academies are now putting out, this has been the passion of that group, the Leadership Consortium, for 20 years. And I believe there's a publication that's coming out after the first of the year that is trying to shift our thoughts about health data from being something that is commoditized and packaged to being that our health data is a public resource. Now, it has to be protected. We don't want any of our patients giving up their rights to how their data are, legally used in any way, and it has to be very carefully protected. And patients have to be the start of this whole process. They have to be at the head of the line for this process, because remember, without trust, we are nothing. But maybe we can shift our thought about our health data, that our health data is a public utility. Kind of like electricity, you know? We all need electricity. Nobody says, well, and we all need to pay for it. It's not going to be free, but we can all get electricity at a reasonable societal price.
I love that
to do what
analogy.
we do. What my hope is that health data from every little corner of our health environment can be like electricity. It's safe. You're not going to get shocked when you plug it in. It's safe. It's reliable. And the innovators can have access to it and then do wonderful things with their innovation. So that's what we're trying to see happen.
That's a bright future you painted
That's
for
what we
all
need.
of us.
That's the only way we're going to see the true promise of AI in health. And it's the only way we're going to earn the trust of the people we serve.
I think we have a guidepost.
Okay.
We should
Let's
grow
do it.
the AI field like we are using the electricity
There you go.
nowadays. Well, it's been a wonderful conversation. Thank you so much, Monica. By the way, I heard from Grapevine that you are nominated to be the president of National Academy of Medicine. I'm so thrilled. I can't wait for you to take your post.
Well, I've been nominated, and the members have to agree with this nomination. So there will be a vote of the members.
I can't see anybody against this.
But if the members agree with this nomination, it will be my great honor. I can't wait.
This is fantastic. You will do great things again, as you always have done.
Thank you for listening to this episode of All Things Cancer. Be sure to subscribe so you never miss future conversations. To learn more about how the National Foundation for Cancer Research is working with the global research community to make cures possible, visit nfcr.org. You can also reach us directly at 800-321-CURE.